Welcome to the deep dive. We're jumping straight into a massive stack of sources today.
Oh, yeah, we've got a lot to cover.
We really do. We're looking at clinical guidelines, heavy-hitting orthodontic texts, and some truly paradigm-shifting genetic research. And it is all tailored specifically for you today.
It's some of the most fascinating material we've reviewed.
All right, so our mission is to explore the hidden and, frankly, incredibly frustrating world of teeth that simply refuse to enter the mouth.
The ones that just get stuck.
Exactly. We are focusing this deep dive on two intensely interrelated clinical realities. First, we're looking at the mystery of the unerupted maxillary central incisor.
Basically, the complete absence of the front teeth.
Right. And second, we're shifting gears into this biological enigma known as primary failure of eruption, or PFE, where the fundamental biology of tooth movement just inexplicably hits a brick wall.
It's wild.
Okay, let's unpack this. If you think about normal dental eruption, it's like a highly choreographed physiological dance, right?
Yeah, that's a good way to look at it.
Or like a biological train arriving at a perfectly scheduled station. The tracks must be completely clear of debris, the cellular engine driving the tooth has to be firing on all cylinders, and the developmental timing has to be absolute perfection.
It's a very delicate system.
Right. But we are looking at what happens when there is a literal boulder sitting on those tracks.
Right.
Or, even more baffling, what happens when the tracks are completely clear, the pathway is wide open, but the cellular engine of the tooth simply fails to ignite.
And what's truly fascinating here is how the management of these eruption failures really highlights a massive paradigm shift in modern oral health care.
How so?
Well, we've historically viewed orthodontics and oral surgery through a purely mechanical lens, applying brute force, wires, brackets to physically drag anatomy into compliance.
Yeah, just pulling things into place.
Right. But the material we're reviewing today demonstrates a total pivot. We're moving from macroscopic surgical intervention down to the molecular and genetic level.
Down to the DNA.
Exactly. Clinicians are now utilizing targeted biological protocols and genomic mapping down to a simple saliva swab, honestly, to solve what previously looked like insurmountable mechanical mysteries.
Wow.
We're actually mapping the microscopic signaling pathways that dictate whether a tooth will migrate through alveolar bone or just permanently fuse to it.
That is incredible. But let's start with the classic roadblock scenario first. The unerupted maxillary central incisor.
The missing front tooth.
Yeah, and this isn't some fringe anatomical anomaly, right?
No, not at all.
The permanent maxillary central incisor stands as the third most commonly impacted tooth in human anatomy. It trails only behind the third molars, the wisdom teeth, and the maxillary canines.
The clinical incidence is pretty significant. The sources show it ranging anywhere from 0.04% up to 2.6% of the general population.
And looking closer at those prevalence rates, there's a really pronounced demographic skew.
Yeah, the male-to-female ratio.
Right. The data clearly indicates a strong male predilection with a ratio of 2.7 to 1. So, if you are a male listener, the statistical probability of encountering this specific developmental hurdle during childhood is notably amplified.
It's a huge difference. And the functional and psychosocial ramifications of this are profound.
Absolutely.
But for you, or for a patient sitting in the chair, a missing central incisor is vastly more than just a compromised aesthetic.
It's not just a gap in a smile.
Not at all. You have a patient, typically in their formative prepubescent years, navigating intense social development with a glaring void right in the front of their face.
The psychosocial burden, the low self-esteem, it's immediate.
Immediate. But functionally, it alters the entire biomechanics of the anterior maxilla too. The patient loses the ability to properly incise food.
And the speech issues.
Exactly. The absence of that anterior stop completely distorts speech articulation. It specifically causes severe impediments with sibilant sounds.
Like the OSA.
Right. Most notably the es pronunciation. If the tongue doesn't have that palatal surface of the incisor to articulate against, the speech pathology becomes deeply ingrained.
So the clinical imperative to intervene is absolute. But to treat it, the clinician has to first understand the etiology, right? Like, why did that specific anterior tooth stall out?
Yeah, you have to find the why before you can fix it.
And the sources stratify the causative factors, starting with localized environmental disruptions.
The most prevalent environmental factor being direct trauma to the primary dentition.
The baby teeth.
Right. Consider the classic childhood injury. A toddler falls and sustains an intrusive luxation of the primary central incisor.
Basically, they smash their front baby tooth up into the gum.
Yes. And that physical impact doesn't just damage the baby tooth. The kinetic energy is transmitted directly through the apex of the primary root, straight into the developing permanent tooth follicle that's resting deep within the jawbone.
And then that leads to delaceration.
Exactly. This localized trauma disrupts the highly sensitive Hertwig's epithelial root sheath of the permanent tooth, leading to delaceration.
Which is essentially a severe anatomical distortion, right?
Very severe.
The childhood injury traumatizes the developing germ, and as the permanent root continues to form over the next several years, it bends at this severe unnatural angle.
It just veers off course.
Right. Instead of developing along a straight vertical vector toward the gum line, the root might form at a 90-degree angle. It drives the crown of the tooth completely off its eruptive path, sometimes pointing it straight up toward the nasal floor.
You literally have a train actively steering itself off the tracks.
And that anatomical distortion is permanent.
Sadly, yes. And alongside direct trauma, other environmental roadblocks include the premature loss of a primary tooth.
Because the space closes up.
Exactly. When a deciduous tooth is lost too early, the adjacent teeth naturally drift into the void. They physically constrict the arch length and completely obliterate the space required for the permanent incisor to erupt.
And conversely, the over-retention of a primary tooth, or even an intrabony cyst, acts as a dense physical barrier.
Right. But as we move into the hereditary and structural anomalies, the sheer volume of cases driven by supernumerary teeth is staggering.
The extra teeth.
Yeah.
Statistically, supernumerary teeth are the dominant physical roadblock. They are responsible for anywhere from 28% to a massive 60% of all maxillary incisor impactions.
The dental lamina basically goes into overdrive and forms a completely extra structure right in the eruptive pathway.
And it's essential to differentiate the morphology of these supernumeraries because their shape dictates their clinical behavior.
Absolutely. You're generally looking at either tuberculate or conical supernumeraries.
Let's break those down.
Sure. Tuberculate supernumeraries are essentially these malformed barrel-shaped masses of enamel and dentin. They often present with multiple cusps.
They sound kind of gnarly.
They are. They typically develop later than the normal dentition, and they almost exclusively position themselves on the palatal aspect of the permanent incisor.
Behind it.
Right. And because of their bulky, blunt morphology and their delayed calcification, they rarely erupt themselves. They just sit in the bone like a vault door, definitively blocking the permanent incisor from descending.
Wow. And you had to contrast that with the conical supernumeraries, which the sources often refer to as mesiodons.
Right, the mesiodons.
These are smaller, peg-shaped teeth that usually form much earlier. And because of their streamlined conical shape, they might actually erupt into the mouth. Or they might simply deflect the permanent incisor.
It just pushed out of the way.
Yeah, they push the real tooth out of alignment, creating a severe rotation or a labial displacement. But they don't necessarily act as an impenetrable wall the way a tuberculate anomaly does.
We also see more disorganized barriers, like odontomas,
Right.
which are benign hamartomatous lesions. Unlike a formed extra tooth, a compound or complex odontoma is just a disorganized mass of dental tissues. Enamel, dentin, cementa.
It's just a jumbled mess.
Exactly, all chaotic and calcified, creating an absolute physical blockade.
And of course, multiple unerupted teeth in supernumeraries are a hallmark of broader genetic conditions too, like cleidocranial dysplasia.
Where a mutation in the RUNX2 gene disrupts overall skeletal and dental development.
Leaving patients with dozens of unerupted permanent teeth trapped beneath the bone. So with all these potential obstructions hiding beneath the gingiva, the diagnostic burden on the clinician is heavy.
It's a real puzzle.
And the diagnostic phase relies entirely on developmental timing. There are very specific chronological red flags.
The primary indicator being asymmetrical eruption.
Right. If the contralateral incisor, the opposite front tooth, has erupted, and 6 months have passed without its partner appearing, you have a definitive problem.
Normal eruption physiology dictates that contralateral pairs typically emerge within a few months of each other. A 6-month delay is a physiological alarm bell.
And another critical red flag is a discrepancy between the upper and lower arches, right?
Yes. Typically, the lower incisors erupt first, followed closely by the uppers. If the maxillary incisors are missing a full year after the mandibular incisors have established themselves in the arch, the clinician has to immediately initiate an investigative protocol.
And that protocol begins with a tactile clinical exam. The clinician is physically palpating the gums, high up under the upper lip and tracing the roof of the mouth, searching for the bony contour of the hidden tooth.
They're feeling for a bulge.
Yeah. They are mapping the arch perimeter, calculating any space loss, and analyzing the tipping angles of the adjacent lateral incisors to see if they're drifting into the central void.
The physical palpation only provides a rudimentary surface map. The real diagnostic power lies in radiographic imaging.
The X-rays.
Exactly. Historically, clinicians relied on the parallax technique using standard 2D radiographs.
This is so fascinating to me. It's rooted in basic geometric principles, commonly taught as the Eslovi rule, right? Same lingual, opposite buccal.
Yep, the Eslobi rule. Because a single 2D X-ray compresses a three-dimensional anatomical structure into a flat image, you cannot determine depth.
You don't know if the impacted tooth is sitting close to the lip or deep in the palate.
Exactly. So by taking two separate radiographs and physically shifting the X-ray head between the exposures, the clinician analyzes how the impacted tooth appears to move relative to the fixed roots of the adjacent teeth.
It's an optical illusion almost.
Sort of. If the impacted tooth appears to move in the same direction as the tube shift, it is located palatally. If it moves in the opposite direction, it's located buccally toward the lip.
It is a brilliant, low-tech application of spatial geometry. But the clinical landscape has fundamentally evolved beyond 2D limitations now.
Thank goodness.
Yeah. Modern diagnostic protocols heavily mandate the use of 3D cone beam computed tomography, or CBCT.
When you are dealing with a tooth trapped in the maxilla, a 2D image simply cannot give you the precise morphological data you need. A CBCT scan provides a high-resolution volumetric rendering of the entire maxillofacial skeleton.
And the clinical value of that 3D volume cannot be overstated. When a surgeon is planning to access an impacted incisor, they need to know the exact degree of root delaceration.
Is the root hooked at the apex? Is the crown rotated 180 degrees?
More critically, the CBCT allows the clinician to slice through the volume microscopically to assess for root resorption.
This is huge. An impacted incisor, or the supernumerary tooth blocking it, can exert eruptive pressure on the roots of the adjacent healthy teeth. It literally dissolves them away.
And standard 2D imaging suffers from superimposition. The overlapping shadows hide this resorption until it is catastrophically advanced.
The CBCT provides the definitive spatial map required to plan the surgical rescue mission safely.
Okay, so the diagnostic puzzle is solved. You've identified the tuberculate supernumerary blocking the central incisor, you've mapped its exact location with the CBCT, and now it is time for the rescue mission.
The actual treatment.
Right. And here's where it gets really interesting, because the treatment completely changes based on the patient's exact age and root development.
The Royal College of Surgeons, the RCS, established definitive clinical guidelines for this. And the entire surgical philosophy is dictated by the microscopic developmental stage of the tooth's root.
Because the underlying principle driving these guidelines is the biological engine of the tooth itself.
Exactly. A tooth does not finish growing the moment the crown is fully formed. The root continues to develop, driven by the apical complex, for years after the tooth emerges.
And as that root lengthens, it generates immense eruptive potential.
The surgical strategy has to harness that natural biological force rather than fighting it or, inadvertently destroying it.
So let's examine the first demographic cohort in the RCS guidelines, patients under 9 years old.
The SOT approach.
Right. The prescribed protocol is governed by the acronym SCT: space creation, extraction of the obstruction, watchful waiting, and finally traction, but only if absolutely necessary.
The restraint required in this protocol is immense.
I bet.
For a patient under 9, the permanent incisor's root is still actively forming. Its inherent eruptive drive is at its peak. Therefore, the mandate is maximal biological conservation.
So what does the surgeon actually do?
The surgeon will reflect the soft tissue just enough to access and extract the tuberculate supernumerary or the odontoma. However, the critical rule is that they absolutely must not uncover the bone surrounding the impacted permanent incisor itself.
Right. They go in, remove the extra tooth, and deliberately leave the actual permanent incisor completely buried and untouched. Why the extreme caution there?
Because the impacted tooth is surrounded by a highly specialized, delicate layer of tissue called the dental follicle.
The sac around the tooth.
Exactly. This follicle is not just a protective sac. It's a dynamic organ packed with stem cells and signaling molecules that orchestrate the entire eruption cascade.
It directs the osteoclast to clear bone ahead of the tooth and the osteoblast to build bone behind it.
Right. If a surgeon aggressively uncovers the bone and violates that follicle prematurely in a young patient, They risk permanently destroying the very biological mechanism that would have naturally brought the tooth down.
Wow. So they clear the path, ensure there's adequate arch space, often by placing a localized orthodontic space maintainer, and then they initiate the W in the SET protocol. Watchful waiting.
And the waiting period is astonishing.
The guidelines recommend observing the patient for up to 18 months.
18 months.
If you are counseling a parent whose 8-year-old child has a massive gap in their smile, telling them you're going to perform surgery to remove an extra tooth, but then effectively do nothing but wait for a year and a half for the real tooth to drop, that requires immense clinical confidence in patient management.
It really does. It demands an exceptional level of trust from the patient and parents. But the empirical data unequivocally supports this conservative approach.
The stats are great.
By simply removing the physical barrier and allowing the pristine, undisturbed follicle to do its job, between 49% and 91% of these impacted incisors will spontaneously erupt into the oral cavity without any further surgical or orthodontic traction.
The inherent biology, when unhindered, is remarkably effective.
It really is.
But biological potential is finite. As the patient ages, the strategy must become more aggressive. For patients aged 9 to 10, the RCS guidelines shift to the SET protocol. The watchful waiting period is drastically truncated.
Because at 9 to 10 years of age, the root of that maxillary central incisor is either fully formed or nearing completion.
The apical complex is closing.
Right. The internal engine driving that spontaneous eruption is winding down. So the clinician still extracts the obstruction and ensures space, but the watchful waiting is capped at 12 months.
A year.
Yeah. If spontaneous eruption hasn't occurred within that year, the clinician must intervene surgically to expose the tooth and apply active orthodontic traction.
And for patients presenting over the age of 10, categorized as late referrals, the biological window has effectively closed.
The eruptive potential is considered negligible.
For these patients, the protocol abandons watchful waiting entirely. In a single surgical intervention, the clinician extracts the obstruction, creates the space, and immediately surgically exposes the impacted incisor to bond an orthodontic attachment.
There is zero biological advantage to delaying traction at that stage.
And the mechanics of that surgical exposure represent a fascinating divergence in clinical technique.
It really does.
When a tooth requires active traction, the surgeon must choose between an open exposure and a closed exposure technique. And the anatomical location of the impacted tooth and the quality of the overlying gum tissue dictate this decision.
Let's look at the open exposure first.
Yeah,
This
okay.
is relatively intuitive. If the impacted tooth is positioned superficially, specifically under a robust band of keratinized tissue, the surgeon can perform an apically repositioned flap or excise a small surgical window in the mucosa.
They just cut a little window.
Yeah. This physically leaves the crown of the impacted tooth exposed to the oral cavity. The orthodontist has a direct, dry field to acid etch the enamel, bond a standard bracket to it, and immediately begin applying elastic or wire traction to guide it down.
It is mechanically straightforward, but anatomically limiting, right?
Very. If the tooth is impacted high up in the alveolar vault, under highly mobile, non-keratinized alveolar mucosa, an open window technique is contraindicated.
Because if you drag a tooth through non-keratinized tissue, it will emerge without a healthy collar of attached gingiva. That leads to severe chronic periodontal recession and aesthetic failure.
It looks terrible and it's unhealthy. This is where the closed eruption technique becomes mandatory, and it is a marvel of surgical engineering.
The closed technique is so counterintuitive to me. The surgeon elevates a massive full-thickness mucoperiosteal flap, peeling back the gum and periosteum to reveal the bone.
They carefully remove just enough alveolar bone to expose the hidden crown of the incisor.
Then, while fighting to maintain a perfectly dry field amidst bleeding bone and saliva, they bond an orthodontic eyelet or bracket directly to the enamel.
Which is incredibly hard to do.
I can imagine. And attached to this bracket is a delicate gold chain. But then, instead of leaving it open to pull, the surgeon completely repositions the entire mucosal flap and sutures it tightly back into place, burying the tooth all over again.
The only visible evidence of the surgery is the terminal end of that thin gold chain exiting through the sutured incision line.
Wait, so they just leave the gold chain hanging out of the gun?
They do. The surgical difficulty of a closed exposure is substantial. Achieving absolute hemostasis, stopping the bleeding perfectly so the composite resin can chemically bond to the etched enamel deep within a surgical crypt is highly stressful.
Because if that bond fails, weeks later due to moisture contamination during surgery?
The patient has to undergo the entire procedure a second time.
Wow.
However, the physiological payoff justifies the difficulty.
Because it mimics nature.
Precisely. By burying the tooth and pulling the gold chain through the tissue, the orthodontist is simulating physiological eruption.
As the tooth is slowly winched downward, millimeter by millimeter over several months, it pulls the surrounding bone and soft tissue with it.
It emerges through the alveolar ridge, enveloped in a robust natural collar of healthy keratinized gingiva.
The long-term periodontal architecture, the stability of the bone levels, and the final aesthetic gum contour are vastly superior to what you achieve with an open window technique in those high impactions.
It is a phenomenal synchronization of oral surgery and orthodontic biomechanics.
It really is. But the literature we reviewed does not gloss over the failures. What happens when the rescue mission is fundamentally unviable?
Like when the anatomy just won't allow it.
Right. What if that CDCT scan reveals a delaceration so severe that the root is bent 180 degrees? If you apply traction to that crown, the root apex would literally perforate straight through the labial plate of the maxilla.
It would come right through the bone under the nose.
Exactly. Or what if the tooth has undergone severe ankylosis, completely fusing to the surrounding bone? You can't pull bone through bone.
In those catastrophic scenarios, extraction is the only recourse. But the execution of that extraction requires immense foresight.
You aren't just removing a tooth, you are managing the future of the anterior maxilla.
Right. If you simply extract a high, deeply impacted incisor, the resultant surgical trauma will cause massive volumetric collapse of the alveolar bone.
The bone just melts away.
The bone will resorb, leaving a severe concavity. If the long-term plan is to restore that missing incisor with a titanium dental implant once the patient stops growing, that catastrophic bone loss will make implant placement impossible without extensive secondary bone grafting surgeries.
Which leads to the coronectomy protocol.
A great alternative.
Yeah. Instead of gouging the entire tooth out of the bone, the surgeon carefully sections the tooth, removes only the enamel crown, and intentionally leaves the healthy ankylosed root buried deep within the maxilla.
That buried root acts as a biological space maintainer. It preserves the vital width and height of the alveolar ridge, maintaining the perfect foundation for a future implant.
And in specific clinical environments, usually major hospital settings, there is the option of autotransplantation.
This is wild.
If the patient happens to require the extraction of a developing premolar due to severe orthodontic crowding, the maxillofacial surgeon can carefully extract that vital premolar and immediately transplant it into the surgically prepared socket of the missing central incisor.
They just move the tooth.
Yeah. If the donor premolar has an open apex and an intact periodontal ligament, it can establish a new vascular supply, reattach to the bone, and function as a vital front tooth.
The orthodontist then meticulously reshapes and bonds composite to that premolar to aesthetically camouflage it as a central incisor.
It is the ultimate surgical salvage operation.
It is.
But all of this intricate planning, the 3D imaging, the gold chains, the autotransplantation, it's entirely predicated on the concept of mechanical failure.
Right, we are fixing a physical problem. An obstruction, a bent root, an abnormal position.
Which transitions us to the second, vastly more complex half of our deep dive. What happens when there is absolutely no physical obstruction?
The bone is healthy, the pathway is perfectly clear, the root is straight.
But the tooth simply refuses to move.
We are entering the domain of primary failure of eruption, or PFE.
And this moves us away from macroscopic mechanical roadblocks and plunges us deep into a microscopic molecular dysfunction.
PFE is an exceptionally rare condition. It presents with an incidence rate of approximately 0.6% in the general population.
Very rare.
It is clinically defined as a non-syndromic failure of permanent teeth to erupt, despite a completely clear eruption path. The biological engine just shuts down.
The anatomical presentation of PFE is incredibly specific and visually striking. It predominantly affects the posterior segments of the dental arch, the premolars, and the molars.
And it frequently manifests bilaterally, affecting both sides of the jaw simultaneously.
The hallmark clinical sign is a severe posterior open bite.
The visual impact on the occlusal plane is profound. You have a patient who bites down, and their anterior incisors contact perfectly. But as you look posteriorly, the premolars and molars are submerged deep within the alveolar bone.
There is a massive vertical gap between the upper and lower back teeth.
These patients suffer from a severe functional deficit. They literally cannot masticate their food properly because their posterior grinding teeth never meet.
Yet cephalometric analysis confirms that their overall vertical facial growth and skeletal development are completely normal. The jawbone is the correct dimension, but the teeth are anchored in the basement.
When a clinician sees submerged teeth, the deeply ingrained orthodontic instinct is immediate.
Bond brackets to those submerged molars use the fully erupted anterior teeth as an anchorage unit and use heavy elastic traction to pull those molars up out of the bone.
It worked for the impacted incisors, so why wouldn't it work here?
Right, so why not just put braces on them and pull them up like the incisors?
This is where the pathology of PFE becomes a clinical nightmare. The fundamental unyielding rule of primary failure of eruption is that affected teeth do not respond to continuous orthodontic force.
Never.
Never. Applying traction is not just ineffective, it triggers a catastrophic biological cascade. To understand why, we have to look at the anatomy of the periodontal ligament, the PDL.
The PDL is the microscopic hammock of specialized connective tissue, specifically Sharpie's fibers, that suspends a tooth within its bony socket.
It is roughly 0.2 millimeters thick.
Super thin. It acts as a shock absorber during chewing, but more importantly, it is a highly active sensory and remodeling organ.
Right. When an orthodontist applies continuous force to a normal tooth, the PDL undergoes mechanotransduction.
On the side where the PDL is stretched, the tension side, it signals osteoblasts to lay down new bone. On the side where the PDL is compressed, it signals osteoclasts to resorb bone.
This orchestrated breakdown and buildup of bone is exactly how teeth move through the jaw.
But in a tooth affected by PFE, that mechanotransduction pathway is fundamentally broken.
The moment continuous orthodontic traction is applied to a PFE-affected molar, the periodontal ligament undergoes necrosis. It dies.
The protective fibrous barrier disappears entirely.
Consequently, the cementum on the root surface fuses directly, molecularly, to the surrounding alveolar bone.
This is the definition of ankylosis. The tooth becomes biologically welded to the jaw skeleton.
And once it is ankylosed, physics takes over. Newton's third law. For every action, there is an equal and opposite reaction.
If an orthodontist has a heavy wire anchored to healthy front teeth, trying to pull up on a newly ankylosed, immovable back molar, the back molar doesn't budge a micron.
Instead, the reciprocal force drives the healthy, anchored front teeth straight down into the bone.
Oh no.
Yeah, the collision actively intrudes the healthy dentition, drastically worsening the patient's open bite and creating a massive skeletal and dental discrepancy. It is an iatrogenic disaster.
For decades, this unexplainable ankylosis upon application of force was a total mystery. Why were these specific posterior teeth self-destructing their PDL?
The answer was finally isolated, not in the biomechanics, but in the patient's genome.
The genetic breakthrough isolated the mutation to a single gene, the PTH1R gene.
The parathyroid hormone receptor 1 gene. A mutation here is the absolute smoking gun for primary failure of eruption.
If we connect this to the bigger picture, the mechanism becomes clear, right?
Absolutely. The eruption of a tooth requires an eruptive pathway to be cleared through the dense cortical bone of the jaw. The tooth relies on specialized cells called osteoclasts to resorb that overlying bone.
However, osteoclasts do not act autonomously. They require explicit biochemical signaling to differentiate and function.
And the parathyroid hormone receptor 1 is a critical G protein coupled receptor situated on the cells of the dental follicle. It is responsible for receiving signals that recruit mononuclear cells and direct them to fuse into active multinucleated osteoclasts.
So when a patient carries a mutation in the PTH1R gene, that specific receptor is malformed.
The biochemical signal is dropped.
The osteoclasts are never properly activated. The erupting molar tries to push upward, but the bone above it is never resorbed.
The tooth essentially crashes into the unyielding seal.
A single microscopic typo in the DNA halts a massive anatomical structure. That is wild.
And the inheritance pattern of this mutation adds significant complexity to the clinical diagnosis. It is an autosomal dominant trait, meaning a patient only needs to inherit one copy of the mutated gene to express the condition, and there's a 50% chance of passing it to their offspring.
Familial inheritance accounts for roughly 10% to 40% of diagnosed cases. However, the genetic expression is subject to severe variable expressivity.
Variable expressivity is the wild card.
What does that mean exactly in this context?
It means that even within the exact same family lineage, carrying the exact same PTH1R mutation, the physical manifestation can look entirely different.
A father might have a devastating bilateral open bite, affecting every premolar and molar in his mouth.
But his daughter possessing the same genetic defect, might only present with one slightly submerged second premolar, while the rest of her dentition functions perfectly.
This makes relying solely on family history incredibly deceptive during a clinical workup.
Which brings us to a fascinating secondary finding in the genetic literature. The role of the PTH1R receptor is not confined to dental eruption.
It plays a broader role in overall skeletal calcium and phosphate homeostasis and the maintenance of articular cartilage.
The research indicates a compelling link between patients carrying this specific PTH1R mutation and a higher predisposition for developing early-onset osteoarthritis later in life.
Wow. The same receptor dysfunction that fails to regulate localized bone resorption in the jaw during childhood may ultimately fail to regulate the delicate cartilage-bone interface in the joints decades later.
It highlights the profound systemic interconnection of these signaling pathways.
Understanding this genetic foundation completely reframes the diagnostic dilemma clinicians face. The absolute most critical and frankly terrifying scenario described in the clinical literature is the presentation of an isolated, unerupted first molar.
Imagine the clinical puzzle. A 9-year-old patient presents for a routine examination. Their anterior teeth are perfect, the premolars are erupting on schedule.
But one single lower first permanent molar is sitting an inch below the occlusal plane, fully sunken in the bone.
The clinician is faced with a binary diagnostic crisis. Is this just an isolated, mechanically ankylosed tooth, perhaps due to an unrecognized localized trauma or infection?
Or is this the first localized manifestation of the genetic PTH1R mutation? Is this PFE?
Differentiating between the two is paramount because the treatment protocols are diametrically opposed.
If you apply braces to an isolated ankylosed tooth, you might be able to manage the surrounding space or surgically luxate it and pull it into place.
But if you apply braces to a PFE molar, you will destroy the adjacent healthy teeth through reciprocal intrusion.
So how do you solve the puzzle? The clinical guideline is to observe the second molar, the tooth developing immediately distal or behind the sunken first molar.
The behavior of that second molar holds the key. If the underlying pathology is primary failure of eruption, the genetic defect is a field effect. It will invariably affect the teeth posterior to the initial lesion.
Therefore, the developing second molar will also lack the eruptive clearance mechanism.
It will develop, hit the bony ceiling, and stall out alongside the first molar. The open bite will progressively expand posteriorly.
Conversely, if the first molar is merely suffering from an isolated mechanical ankylosis, the second molar does not share the defect. It retains its full eruptive potential.
It will erupt normally, and because teeth have a natural tendency to drift forward into open space, that healthy second molar will actually tip mesily, leaning heavily over the submerged first molar.
However, waiting for that second molar to fully develop and reveal its behavior can take years, during which time the alveolar bone surrounding the submerged first molar is severely degenerating.
This introduces the most radical yet strategically brilliant recommendation in the clinical management of these cases: the early preemptive extraction of the submerged first molar while the diagnosis is still completely unknown.
It sounds like clinical heresy. Extracting a permanent molar without a definitive diagnosis.
But the game theory behind it is flawless. The literature states you have nothing to lose. Let's break down the logic tree.
Okay, option A. You surgically extract that sunken first molar, and it turns out it was just isolated mechanical ankylosis.
By removing the ankylosed tooth, you eliminate the bony defect. The healthy second molar, which is still developing, now has a clear path to drift forward, erupting completely normally into the space previously occupied by the first molar.
It brings a robust, healthy ridge of alveolar bone with it. You have effectively solved the problem using the body's natural drift.
And if we look at option B, you extract the sunken first molar, but subsequent observation reveals the patient actually has the genetic PFE mutation.
In that scenario, the second molar was genetically condemned from the start. It was never going to erupt into occlusion, and it would have inevitably required extraction anyway.
By proactively extracting the first molar early, you prevented a massive localized bone defect from establishing itself, and you haven't sacrificed a single tooth that possessed any potential for functional utility.
It is a diagnostic checkmate. The preemptive extraction is the safest biological bet, regardless of the underlying etiology.
Once a definitive diagnosis of PFE is confirmed, clinicians categorize the severity using the Fraser-Bowers classification system.
The Fraser-Bowers classification helps conceptualize the extent of the eruption failure. Type 1 PFE is characterized by a progressive, anterior to posterior open bite.
The defining feature here is that every single tooth within the affected segment has permanently lost its eruptive potential, regardless of the patient's chronological age or the developmental stage of the tooth's root.
The biological engine is universally shut off across that entire posterior quadrant.
Type 2 PFE presents with a more erratic eruption pattern. The severity of the open bite correlates directly with the specific timing of root development.
In a type 2 presentation, you might see a severely sunken first molar, but the second molar behind it might have managed to erupt slightly further before its engine stalled, resulting in a less severe open bite further back in the arch.
The expression is staggered.
But regardless of whether a patient presents with a type 1 or a type 2 classification, the therapeutic philosophy requires a complete paradigm shift.
The literature emphasizes a stark reality. When managing PFE, understanding what you must absolutely avoid doing is significantly more important than what you actively intervene with.
We know continuous orthodontic traction is strictly contraindicated. So what are the legitimate clinical pathways?
For mild manifestations, where perhaps only one or two premolars are slightly infraoccluded, but the patient maintains adequate masticatory function and acceptable aesthetics, the prescribed treatment is often watchful waiting or complete non-intervention.
You accept the anatomical anomaly and monitor for periodontal health.
However, for moderate to severe cases resulting in a debilitating posterior open bite, the focus shifts to restorative camouflage.
The clinician partners with a prosthodontist to artificially reconstruct the occlusal plane.
This involves meticulously bonding composite resin overlays directly onto the biting surfaces of the submerged molars, physically building them up millimeter by millimeter until they make contact with the opposing arch.
Alternatively, they may prepare the submerged teeth and fabricate elongated custom ceramic crowns to bridge the vertical gap.
The goal is to establish functional mastication without ever attempting to move the ankylosed root within the bone.
But what if the teeth are submerged so deeply in the alveolar bone that a crown would be disproportionately massive, creating a periodontal trap?
For those extreme severe presentations, the literature outlines radical surgical interventions. The primary surgical option is a segmental osteotomy.
A segmental osteotomy bypasses the defective periodontal ligament entirely. The maxillofacial surgeon performs subapical osseous cuts. They literally saw out a massive rectangular block of the alveolar jawbone that houses all the submerged teeth.
They mobilize that entire segment of bone, physically reposition it superiorly into a functional occlusion, and rigidly fixate it to the surrounding skeleton using titanium plates and screws.
They are moving the bone itself, carrying the ankylosed teeth along for the ride.
It is a major surgical undertaking with significant morbidity. And if the bone segment is too compromised or the teeth are too deeply impacted, the final definitive option is the complete surgical extraction of all PFE-affected teeth, followed by extensive bone grafting to rebuild the alveolar ridge, and eventually restoring the entire posterior occlusion with titanium dental implants.
Because the surgical and restorative stakes are incredibly high, diagnostic accuracy is paramount. And the literature issues a severe warning regarding radiographic imaging in these complex cases.
Historically, clinicians relied on standard 2D panoramic radiographs, OPGs, to assess for ankylosis. However, the data reveals a terrifying statistic. OPGs yield a false positive rate for ankylosis of 50%.
A 50% false positive rate is statistically equivalent to a coin flip.
It is.
When a clinician is looking at a 2D panoramic film, the massive distortion, the magnification errors, and the superimposition of the dense cortical plates often create an image that looks identical to fusion.
You cannot commit a patient to a major segmental osteotomy or multiple extractions based on imaging that is wrong half the time.
This is why the contemporary standard of care mandates the use of 3D CBCT scans for any suspected case of PFE or severe ankylosis.
The volumetric data allows the radiologist to analyze the periodontal ligament space slice by microscopic slice in all three spatial planes.
It is the only imaging modality capable of confirming the true presence or absence of that 0.2 millimeter PDL space before committing the patient to irreversible, life-altering maxillofacial surgery.
The journey through this clinical material is staggering.
We have navigated from the macroscopic mechanical physical realities of teeth blocked by dents, tuberculate extra bones, and traumatic tissue delacerations.
We explored the elegant age-based surgical protocols, the SET and SET guidelines that harness the biological power of the developing follicle, using delicate gold chains to simulate natural eruption and preserve periodontal architecture.
And then we transitioned into the microscopic molecular realm of primary failure eruption. we examined the profound anatomical consequences of the PTH1R gene mutation, detailing how the loss of a single biochemical signal to the osteoclasts leads to catastrophic mechanotransduction failure, resulting in absolute, immovable ankylosis of the dentition.
It forces you to appreciate the breathtaking complexity and the fragile, perfect timing required for human biology to produce something as seemingly simple as a normal smile.
A microscopic variation in a single parathyroid hormone receptor can entirely alter the skeletal architecture of the jaw, rendering decades of traditional orthodontic mechanics completely useless and demanding radical surgical or restorative workarounds.
The complexity is humbling, but the future trajectory of this field is what truly captivates me. The current literature highlights that we are now utilizing simple saliva swabs to definitively sequence the PTH1R gene, diagnosing PFE before an orthodontist ever places a single bracket.
We are diagnosing structural skeletal defects via genomics.
This represents a monumental leap, but consider the implication. If we are already routinely sequencing the genome to dictate orthodontic treatment plans, how rapidly are we approaching the era of personalized molecular dentistry?
The potential there is limitless.
Consider the precise mechanism. We have identified the specific failure point. The PTH1R receptor on the dental follicle fails to recruit osteoclasts. Could the future of orthodontics pivot from applying mechanical tension to administering targeted biological therapies?
Imagine a clinical protocol where, instead of extracting teeth or performing segmental osteotomies, a clinician delivers a localized injection of a synthesized protein directly into the alveolar crypt.
Or perhaps utilizing a targeted CRISPR-Cas9 viral vector to precisely edit the localized cellular DNA, repairing the osteoclast signaling pathway, and manually reigniting the eruption engine.
If we can manipulate the biochemical cascade of tooth movement at the cellular level, we may reach a horizon where traditional mechanical braces are rendered entirely obsolete for these conditions. We wouldn't fight the biology with wires, we would simply rewrite the localized biological instructions.
From physically wrenching teeth through bone with titanium and gold to reprogramming the DNA of the alveolar crypt itself.
It is a profound thought to end on. We hope you enjoyed navigating this incredible depth of source material as much as we did. Thank you so much for joining us on this deep dive, and we will see you on the next one.